Hi, this is Dr. Kevin Kirby, and I want to continue my series on the medial and lateral heel skive techniques now. When we start looking at the medial heel skive and the types of patients that we would use this orthosis technique on, it's evident that they work best and make the most biomechanical sense to use on patients who suffer from subtalar joint pronation-related pathologies. And the two types of patients I'm going to be covering in this lecture are going to be the pediatric flat foot deformity and the pes planovalgus deformity that's evident in patients with posterior tibial tendon dysfunction. To start out, flat foot deformity is not only common in children, but it's also common in adults. Flat foot deformity can cause symptoms due to the abnormal magnitudes of forces acting in the tendons, ligaments, joints, and within the tissues of the foot and lower extremity during weight-bearing activities. So when would we use this medial heel skive modification? What are the patients we would use it for? How do we apply it along with other orthotic modifications? And how do we use it along with also other types of shoes and shoe modifications to effect a better treatment of our patients who suffer from mechanically related disorders of the foot and lower extremity? So for our first case report, we're going to be looking at a pediatric flat foot deformity, which was a patient of mine many years ago. And this was a 9-year-old boy who was brought in by his parents. They complained that he had painful feet, painful ankles, anytime he would run or walk long distances. Sports such as soccer and running with his friends would make the pain worse in his feet and ankles, and walking only produced minimal symptoms unless he did long walks, and then the symptoms would increase. Parents were also worried that he ran with what they called a duck-footed gait. He would run with his feet turned out, abducted or externally rotated more than his friends, and this made them worry also that this may be causing some of his clumsiness when he was running with his friends. The parents had noted that he was not as fast as the other kids and was also just not as efficient running as his friends who were also playing these running sports with him. So when we look at the examination and go through this examination of a pediatric flat foot, I'm going to point out some things that I look at in my clinical treatment of these patients. I've been treating pediatric flat foot patients for the past 36 years. And there are some key features of the clinical examination which I think are important that you can use in your own clinics and to recognize the severity of this pediatric flat foot deformity. So clinical examination of the patient showed that this patient had a lot of range of motion in the subtalar joint, mid-tarsal joints, and in other words, he had increased ligaments laxity. He also is noted on standing what we call a convex medial midfoot. So a normal foot will have a straight line from the medial heel to the medial first metatarsal head, but you see how there's a convexity of the medial midfoot, not only in the left foot, but also in the right foot. And this is a key marker of patients with pediatric flat foot deformity. Also notice there's an abducted angle of gait. And here we see the abducted angle of gait. And also during gait, the patient was relatively abducted and also was apropulsive. When I examined him, I drew a heel bisection. He was 7 degrees everted at the calcaneus in a relaxed calcaneus stance position, and his subtalar joint was maximally pronated. Again, as in the last lecture, I mentioned the maximum pronation test. This is a good time to use the maximum pronation test and also the supination resistance test to determine are they maximally pronated and how much force is required to supinate the foot. So when I went to the clinical examination of this young man and laid him flat on his back and measured the subtalar joint axis by the palpation technique I've described in the last 2 lectures, we see very clearly that there's axis of the subtalar joint is medially deviated. We see here that instead of the axis passing out through the first intermetatarsal space or sesamoids, is passing out basically through the navicular on both feet. So this is a very abnormal axis location for a child or for an adult, and creates mechanical issues in the sense that the ground reaction forces are now going to be causing quite excessive subtalar joint pronation moments, since all the ground reaction force on the lateral aspect of the foot, lateral to the subtalar joint axis, is going to produce high amounts of pronation moment. So medial to the axis, we see there's very little surface area by which for a ground reaction force or an orthosis to produce a supination force in this small area just medial to the subtalar joint axis in this 9-year-old boy. Here, the black arrows indicate where the axis should be in a 9-year-old boy at a normal foot with normal function. So this is a large amount of distance by which ground reaction force can increase the pronation moments acting on the foot during gait than if he had a more normal axis. In this flat-footed child, we used a relatively rigid shell material for him when we made orthotics. We used a fairly long rear foot post, and the rear foot post is long. Since the longer the rear foot post, the stiffer the plate will be. I will use in these children anywhere from a 3 to an 8 millimeter medial heel skive. The most common medial heel skive amount I use is 4 millimeters. 8 is rare. 3, 4, and 6 millimeters is fairly common in my practice. As we start going higher with the amount of medial heel skive, we then need to increase the heel cup depth. If I'm using a 2 millimeter medial heel skive, I will use a 16 millimeter heel cup depth. But anything over 3, 4, 5, or 6 millimeters, I use 18 millimeters. And if I'm going up to an 8 millimeter skive, I would tend to do a 20 millimeter heel cup height. I also will tend to balance these orthoses for these children more inverted in order to increase the medial arch height. Again, as I mentioned in the last lecture, the best way to treat flat foot deformity so that we can increase the supination moment not only in the heel but also in the medial arch is to not only use a medial heel skive, but to increase the pressure in the medial arch area so that we have a transfer weight from lateral to medial. In this fashion, by using an orthosis that is balanced inverted, we can increase the medial arch height, which is going to be increasing the ground reaction force not only on the heel but also in the medial arch to optimize the control of pronation of this patient's foot with orthosis. If I see equinus is present in the child or adult, I will also use a thicker heel contact point. I can have the lab add on polypropylene thickness to the heel cup when they grind the orthosis or when they use a CAD-CAM process on the orthosis to increase the heel cup height. And this will take the force of the Achilles tendon away from pronating the foot and get better control of the foot pronation when we use a thicker heel contact point in the orthoses with equinus deformity. I also will tend to use a minimal medial expansion plaster in the positive cast. In essence, this increases the arch height. Higher amounts of medial expansion plaster will tend to lower the arch height, but in children's flat feet, I will tend to use minimal medial expansion plaster so I can get a nice amount of force underneath the medial arch here of the child with a flat foot deformity. So here's our child. Again, as I mentioned before, convex medial midfoot. A talus has rotated medially and planarly. We see this flat arch, medial arch structure. So the medial longicular arch structure is quite flat in this patient when we see it close up. But when we put the orthotic underneath it, it's quite amazing the correction we were able to achieve with this type of orthosis. And the patient's foot was very visibly changed when he stood on the orthosis versus when he didn't have the orthotic on. Here is our 9-year-old boy barefoot with a pes planus deformity and relaxed bipedal stance. We see the flat arch, we see the talus pointing medially. Instead of a nice concavity in the medial arch, as you should have a 9-year-old child, we have almost a convexity, letting the medial arch contact the ground. When we put them in the orthosis and then put them into a higher cut shoe or mid-cut shoe that's helped support the ankle, there is a large difference in the foot shape and the ankle shape and the morphology of the foot not only during standing, but also the gait had changed dramatically. In this child that we made orthotics for and put him into correct, better shoes, the patient's pain had resolved by 90% at 3 weeks' time. There is increased comfort with running. No problems with the orthosis, such as arch irritation. Parents were quite pleased since they noticed that the child's gait had reduced from a duck-footed gait to more like their other kids in the way he ran. They also noticed he was more efficient. And also, when we subsequently followed him up in the clinic, he was showing continued lack of pain, having more fun playing more, and not running as inefficiently and with such a duck-footed gait as he had before he got the orthotics. So this was a very rewarding case for me in the sense that parents came in complaining of their child. The child was having pain with running. He was getting discouraged and had pain when he tried to play with his friends at running sports. I made orthotics, got him in better shoes, made sure the orthotics worked correctly, and he improved significantly with this treatment. The second most common problem I treat in my own clinic in Sacramento, California, is this posterior tibial tendon dysfunction, and I want to spend the rest of the lecture talking about this pathology since it is very common. I see approximately 3 to 6 of these patients a month, and these patients are having quite a bit of pain and pathology and disability from their posterior tibial tendon dysfunction. So what is posterior tibial tendon dysfunction? Posterior tibial tendon dysfunction is one of the most serious adult flat foot deformities seen. The medial heel skive orthosis is very effective at treating these patients. So the goals of treating posterior tibial tendon dysfunction is to reduce pronation moments acting on the foot by increasing the supination moments with orthosis, shoes, and braces, to reduce inflammation, edema, and pain in the posterior tibial tendon to allow more normal posterior tibial muscle function, to increase the strength of the posterior tibial muscle after the inflammation is resolved so that we can have them walk better with less pain. Again, medial heel skive is going to be very important in trying to push medial to the subtarsal axis and reduce the pain that this patient has in the posterior tibial tendon. Here we see the subtarsal axis on the right foot that has a posterior tibial tendon dysfunction is more medially deviated. Foot orthosis modification we use for posterior tibial dysfunction will include a thicker polypropylene shell, 3/16 or 5 millimeters to 4/16 or 6 millimeters polypropylene shell. We'll use a plastic rear foot post. Medial heel skive will be anywhere from 2 to 6 millimeters. Heel contact points, especially if they have an Aquinas, will be thicker. We'll use a 16 to 20 millimeter heel cup height. And we'll again try to get the medial arch of the orthosis well into the arch of the foot to have both the medial arch and the medial heel skive increase in pronation control on the foot. And we'll also sometimes balance the cast anywhere from 2 to 4 degrees inverted to try to get as much medial arch height as we can without hurting the patient's foot. We also use in more severe cases of posterior tibial tendon dysfunction, stage 2, stage 3, or even stage 4, we'll use an orthosis with a high top shoe. It's important to use the high top shoe with the orthosis in order to get the ankle so it's not leaning medially so much. The boot then will produce a supination moment on the foot since it works also superior to the subtarsal axis. Note here in this diagram that the subtalar joint is, since it's going from the posterior lateral heel to the talus above the orthosis really doesn't have the ability to wrap around the subtalar joint to produce supination effect. It has to have its effect by shifting ground arch force medially, whereas a boot or brace can wrap around the subtalar joint axis both on the plantar and dorsal aspects of the subtalar joint to produce a bracing effect that adds additional supination moment to the foot. And this is why braces and boots, high top boots, work very well for these patients with posterior tibial tendon dysfunction. We can use high top boots. We can use foot orthosis for posterior tibial tendon dysfunction. These are the many braces that are available. I'm sure there's many more, but the same idea is that we're trying to use a brace above the ankle to control the subtalar joint since it can brace both inferior and superior to the subtalar joint axis. And also, I'm a big believer in icing therapy for these patients with tendon swelling along the posterior tibial tendon. I'll have them ice once or twice a day. I'll continue the icing until the swelling reduces and the pain is diminished. And we also may use anti-inflammatory medications in the medial ankle area to try to rid the patient of the ankle tendon edema and pain that many times reduces their ability to walk comfortably. So in conclusion, you need to understand how the subtarsal joint moves in these pes planus feet, whether it's a child's foot or an adult foot with posterior tibial tendon dysfunction, and understand how foot orthosis and braces work to produce the change in supination moments. And the foot orthosis research that needs to be done in the future has to account for these wide variations in subtarsal axis location in order to produce more information for us as clinicians in order to better understand how to treat these patients with pes planus deformity, medially deviated subtarsal axis, and to help us further understand how best to treat these patients with custom foot orthosis. Thank you again, and I'm hoping you enjoy the series.